How y'all doing this evening? So, my name's John Klein, right there. I am from Potomac Urology, as you can see. And the date is January 16, 2008. So anyway, I'm talking today about BPH and treatments for BPH. I think you all saw the flyer about BPH, Rezūm as a treatment for BPH. So I wanted to put together a short presentation about that, what BPH is, what the symptoms are, how it's diagnosed, how it is treated, what the treatment outcome is, just to get you familiar with things. And then after that, I'll be taking a lot of questions. So if you have questions about anything I've said, feel free to ask me questions at the end of the evening, of course. So the prostate, what is it? It is a gland that is between the bladder and the urethra here. The urethra passes right through the middle of the prostate when you pass urine. You can see it from the frontal view over there. The urethra goes right down through the middle of it. So you have to think of the prostate as a donut through which the urethra passes like a donut hole. When you are young, your prostate is a very thin donut with a very large donut hole. You urinate freely and everything goes quite well. As you get older, the donut gets baked a little bit. And it gets plumper and plumper, and that donut hole gets smaller and smaller. And you start to get problems passing the urine through that donut hole as the donut hole gets smaller. So with benign prostatic hyperplasia, BPH, as I'm sure you've heard before, it stands for benign prostatic hyperplasia, or not cancerous, benign, of the prostate. And hyperplasia just means growth. So growth of the prostate in a benign fashion. It's a localized enlargement of the prostate gland in adult men as they get older. So, well, like I said, prostate of a young man right here, large channel goes down right through the middle of it, barely even know it is there. The older you get, this outer part of the prostate stays exactly the same, this outer shell of the prostate. But the inner part of the prostate right here gets larger and larger. That's the part of the prostate which responds to testosterone. Now, everybody's got it if you're a guy. Over time, this testosterone causes that part to get bigger, and you can see over there on the picture on the right that prostate tissue in the middle gets bigger and starts to impinge on the urethra. And that's what causes those symptoms. So first off, how many people have it? And the answer is a lot of people have it. Yeah, a lot of hands already went up, but a lot of people have it. Men don't tend to like to talk about their health conditions very often. So I noticed that people tend to think that this is something they're suffering through alone. And some people do talk about it, some don't, but you're not alone. Every year you have just shy of 1 million men getting newly diagnosed with enlarged prostate, BPH, and urinary symptoms. And there are 12 million men in the U.S. already diagnosed with BPH. And that's probably an underestimate, to be honest. So between 51 and 60, there's historical data to show us that about 50% of men have some element of BPH. Now, if that was the case, and that number in the U.S. would be way more than 12 million people are diagnosed with BPH. The reason, if 50% of men between the ages of 51 and 60, and then even more, older than that, have some element of BPH, you'd think it'd be a lot more than 12 million men. The 12 million men are those that seek care and have a formal diagnosis. So 50% when you hit 50, almost everybody, once you hit 80, has some element of BPH. Doesn't mean you're terribly symptomatic or you're having a terrible time, although some people do, but it means there's some urinary symptoms going on as a result of an enlarged prostate. So, if you say most people have these symptoms, what are the symptoms of BPH? The first is lower urinary tract symptoms, okay? That's the encompassing definition, meaning things associated with your lower urinary tract. Need to pee more frequently during the daytime, but also at nighttime. It may be both, but you notice it more at nighttime because at nighttime you got to wake up in order to pee. During the daytime you just got to walk 10 feet that way, so it doesn't bother you as much. Urgency to urinate, feeling normal one moment and then like flipping a switch. All of a sudden you got to go, and when you got to go, it is now. It's not, we'll wait to the end of the meeting. It's not, we'll wait until 3 more exits down the road. It's that next exit, and it's hold on, I got to get out of the meeting. Difficulty to start urination. So you're running for the bathroom, but when you get there, that feeling's still there, but things aren't really coming out all that much. Straining to urinate to begin, pushing with your abdominal muscles in order to urinate. Flow being poor. So you used to be able to write your name in the snow, not so much anymore. Dribbling after urination. So dribbling after urination happens to men with enlarged prostates as well. You think you're done, you're about to zip up and walk away, and then you're thinking, well, hold on a few more seconds, and you're waiting a few more minutes, and a few more minutes, and a few more minutes. Okay? And those are the common symptoms of it. So if you have those symptoms, is it BPH? And the answer is maybe. There's actually a couple of other different conditions which can also cause those symptoms. An overactive bladder, which happens commonly in diabetics, can also cause some of those symptoms. People who have issues with back problems, can also sometimes have nerve issues that can cause urinary symptoms. There's a whole host of reasons why you can have those symptoms. It's not always BPH. It's most often BPH, but it's not always BPH. So how do you diagnose it? Somebody comes in saying, I have these symptoms. I don't say, all right, let's just take you to the operating room. There's a way of figuring out whether treatment for the BPH, be that medicines, procedures, or surgery, is right for you, or whether we have to focus on something else. And so the methods that we have available to diagnose BPH. The first is questionnaires. Every single patient that sees me for the first time, and most of my patients that undergo follow-up visits, are tracked with a questionnaire called the International Prostate Symptom Score, or IPSS. It's a series of questions where you ask, how many times a night do you get up to urinate? How often do you feel like you have urgency? How often do you feel like you have frequency? How often is your flow poor? How often do you have these symptoms? And you add up the amount of points you get for each of these symptoms, and that comes up with your actual score. And that's repeatable. Meaning if you're feeling worse in 6 months, that score will invariably be worse. If you're feeling better in 6 months, that score will be better. So it's a good method of tracking people for how their symptoms are going. After you start meds, after you do a procedure, all these different things. Prostate imaging, cystoscopy, and truss. So cystoscopy is a tiny camera that gets put through the urethra into or through the prostate and up in the bladder. And that checks for urethral problems, it checks for prostate enlargement and blockage, it checks for bladder problems including bladder cancer, bladder stones, other anatomical issues of the bladder. And that's a picture of cystoscopy, although these days we use video camera systems rather than putting the eye directly on the lens. The other method, and that shows us the shape of the prostate. When you have a camera in there, some people have prostates which have 2 lobes, which squish the urethra, like having 2 walls coming together, squishing the urethra. And some people have prostates that have 3 lobes. 2 lobes coming together from the sides and a third one coming up from the bottom. So that prostate looks a bit more like a Mercedes-Benz sign, with these tiny little cracks where urine can get through. And that distinction can make a difference in how you're treated. And that's why it's important to do the cystoscopy and take a look at the shape of the prostate. The transrectal ultrasound, or TRUS, transrectal ultrasounds meaning it's an ultrasound shaped like a finger. So you do basically a prostate exam with an ultrasound shaped like a finger that allows us not just to feel the prostate for lumps and bumps, which is what the finger exam is for, but also to scan the outside with the ultrasound and figure out a volume. How big is this prostate? Is it 30 cc's? Is it 80 cc's? Is it 200 cc's? Okay? And that tells you a lot about what treatment options might benefit you. Functionally, so we also do what's called a urine flow rate. All right? So sometimes the ultrasound says you're a little bit enlarged. The cystoscopy says you might be a little bit enlarged. But is this really the cause of your problems? Because you can have 2 things. You can have enlarged prostate and an overactive bladder. So we do functional testing, urinary flow rate. We have a testing equipment where you can go pee into a funnel and tells you how quick the urine comes out. The higher the flow, the less likely you are to be obstructed. So that's a simple, non-invasive way of saying, are you not obstructed or are you somewhat obstructed? And there's more complicated versions of that, such as a urodynamic test where we test bladder pressures in conjunction with the flow rate and gives us a little bit better sense of what's going on. But we usually start with this because this is just peeing into a funnel and it's relatively easy to do without any discomfort. That tells us a little bit. We check prostate size. That can be done by an exam, although Our fingers are not good at estimating size. They're good at looking for lumps and bumps. They're not good at assessing size. And that's why I do an ultrasound on almost everybody that presents to my clinic for urinary symptoms. And then symptom severity is an excellent way of determining how much it bugs you. So we can say, yeah, you have a big prostate. It's obstructed when we do the cystoscopy. I mean, it's got this two lobes squishing together. The urine flows through this tiny space between them. But in reality, is it causing you a problem? And so when you do the tests and questionnaires, the International Prostate Symptom Score, if you have an International Prostate Symptom Score of greater than 8, you have moderate symptoms. Okay, you get up in the 20s and 30s and you have severe symptoms. That tells us not only are you having blockage, but this is causing issues that are bothering you. And that, of course, is the most important thing. If things are bothering you, we need to get you on some treatment that's going to make you feel better. So, what are the treatment options? We found out you got BPH. We found out most likely that's what's causing the problem. How do we help? So, there are tons of different treatments. Okay? Less invasive over here on the left, more invasive all the way on the right. So, the first thing, and the hallmark of initial treatment for BPH is called behavior modification, right? Fluid and diet changes. So if people have a major symptom from BPH of, well, I go every 2 hours at night and it's driving me crazy, but it doesn't bother me during the day, then oftentimes we will say drink as much as you want during the day, but after 6 o'clock at night, you kind of cut fluid off and see if that decreases the number of times you go throughout the night. It's simple. It doesn't have any side effects except maybe being thirsty in the morning. And it can work sometimes on a limited basis. The caffeine can also increase the frequency with which you have to urinate. Alcohol can also do those things. And since people tend to drink alcohol before they go to bed at night, that tends to make those symptoms worse in the evening. It's simple stuff. Kegel and bladder retraining can sometimes help as well in terms of people who have a lot of urgency, trying to hold off that urgency. It doesn't really fix the underlying problem. So what are the first-line therapies? All right, the things we've had for years. BPH medications. Flomax, Rapaflo, Uroxetrol, a lot of medications with flow in the title. They're all largely the same. They will give you some improvement in your symptom score. They will make you feel somewhat better. They don't affect the risk of complications from BPH. So say your symptom score is 20 beforehand. It may bring you down to 15 or 10. However, it doesn't affect the progression, meaning that if every year your symptom score gets 2 points worse, starting one of those medications may bring you back down from 20 to 10, but the next year it's going to be 12, and the next year it's going to be 14, the next year it's going to be 16. And so it doesn't affect progression of BPH. Those Flomax medications, they work for a time, but they're usually not a permanent fix. There are second-line medications such as finasteride and dutasteride. These are testosterone conversion blockers. They affect the availability of a certain type of testosterone which works to grow the prostate. They do affect the progression of BPH. They are able to decrease that rate of rise in the symptom score. But they do have some bothersome sexual side effects which some men find quite bothersome. Decrease in interest and decrease in ability sometimes. As a result, it's kind of limited their use, especially more recently. So that brings us to the Rezūm therapy. Now, the Rezūm therapy is a procedural therapy as opposed to a medication. And so some people say, would you wait for the medications to fail first? And in some guys, they do. They say, you know what, I'd rather stay on the meds until it doesn't work anymore. However, the medications do have those sexual side effects. In the case of the Flomax and those type of things, it impedes the ability to ejaculate when you have an orgasm. Some guys really don't like that. It can cause people to be very dizzy sometimes, and people who have lower blood pressures starting the Flomax can cause you to get quite dizzy when you stand up from sitting. You get that kind of wobbly feeling. People don't like it. When that's the case, that's basically option 1B, that they can consider Rezūm as an alternative without those side effects that can be durable without the need for further medications. And I've experienced it in all the different ways. I've had some people that were on the medications for years and they say, you know what, it was working great for a while, now it's just not cutting it anymore. Should we step up to the plate and do something different? And I always And I say, if it's bothering you, that's when we step up to the plate and do something different. Either side effects bothering you or symptoms bothering you. And so then they progress to Rezūm. So everybody gets a trial of those medications. Sometimes those trials are short, about 2 weeks. If it doesn't work or if they get those side effects and go, I really didn't like it, and then they progress on to other things, other procedures, the Rezūm, things like that. But everybody tries those meds, at least for a short time. Some like them, some don't. You move on to other therapies. The Rezūm therapy, like I said, option 1B. It is an outpatient procedure in the office, relatively short, doesn't have those side effects. You get a greater degree of symptom relief than you usually would with those medications, which is to say 50 to 70% reduction in urinary symptoms. So second-line therapies, microwave conductive radiofrequency, microwave therapy and conductive radiofrequency therapy are second-line therapies. To put it shortly and briefly, they just don't work as well as the Rezūm therapy doesn't. In terms of flow data, especially the microwave, it just doesn't cut it. It can relieve some of those symptoms, but it doesn't increase that ability to actually empty the bladder. And so it's being used less and less. Implants, prostatic implants, which are which is a procedure where you take a telescope and you fire stitches through the prostate to kind of tack it away and open up that prostate. It does work. However, like I said, we have those different anatomical configurations. It works in those people who have the 2 lobes to pull those away, but in a more common configuration of the 3 lobes, it can pull the 2 lobes away, but the 3rd lobe just ends up taking most of that space. So it's contraindicated there. And that's why it's often a second-line therapy, because the majority of my patients in my practice that have issues tend to have at least some of that 3rd lobe there. Surgical procedures are the most invasive. Those are lasers. I do laser enucleation of the prostate. Okay? And that's where I basically, if you think of the donut as kind of a glaze layer on the outside, and then the meat of the donut on the inside, and the hole in the middle, a laser enucleation of the prostate is where I carve down through the donut to the glaze layer, and then remove everything, the meat of the donut, and leave that glaze layer in place. So you're leaving that fibrous outer part of the prostate intact to avoid side effects, but removing the rest. And that works great. It takes away urinary symptoms almost completely, but it has, just like the medications, the retrograde ejaculation in almost everybody, and has rare but real incidence of incontinence. And so that's why that's a surgical procedure, which is a therapy which is usually reserved for failure of medications or outpatient procedures. So that's kind of the treatment options as I see them. So, what makes Rezūm a little bit different? Okay, I kind of went through it briefly here, but essentially, it can be considered a procedural therapy which takes the place of medications instead of taking the place of surgery. That people who are on therapies that they're not particularly happy with, but don't want to progress to major surgery, this is an excellent option for people in that space. And there's a lot of people in that space where, you know, I really don't like the meds all that much, but man, I don't want to go to the hospital and stay overnight and get an actual surgery with full anesthetic and all these different things. It just makes me concerned. I'm not ready for that. This is an excellent option for those in the middle. So essentially the way the Rezūm therapy works is telescope goes in the bladder, a needle comes out of that telescope. The needle is used to pierce the prostatic urethra and go into the prostate. So basically you're going into that donut hole and you're using that needle to push into the donut. And then that needle is used to inject steam. It's generated from water, it's piped through that needle and into the prostate. And that steam goes in there and it essentially kills a few of the prostate cells. A controlled amount of that prostate tissue is killed each time. It's an exact injection of exactly the same amount of steam each time, which results in about 2-centimeter ball of prostate tissue that ends up getting killed. And then that tissue fades away in time, and that opens the channel.
Rezūm uses the natural energy stored in water vapor, or steam. It is a safe and effective treatment available to relieve symptoms associated with benign prostatic hyperplasia, or BPH. During each 9-second treatment, sterile water vapor is released throughout the targeted prostate tissue. When the steam turns back into water, all the stored energy is released, causing the cells to die. Over time, your body's natural healing response removes the dead cells, shrinking the prostate. With the extra tissue removed, the urethra opens, reducing BPH symptoms. Most patients begin to experience symptom relief in as soon as 2 weeks, and maximum benefit will occur within 3 months.
When you go through that procedure, it takes about 5 minutes in the office. It can be done under sedation if people are anxious. We have an anesthesiologist that does that for us in the office. Or under a local anesthetic if people want to stay awake. I've done it both ways, and people are pretty happy either way as long as they get to pick the one that they want to use. And it's about a comfort and about convenience. So when I do that, I'll just tell you a little bit about procedure day. When I do that procedure, people come in, anesthesiologist interviews them, I interview them. We get them into the procedure room, and that procedure is done. A telescope is put up the urethra. It's used to deploy that steam. Each injection of the steam is 9 seconds. It's all done in one sitting. You don't have to come back for more injections later. So the entire procedure is probably about 3-4 minutes. We're injecting steam. I'm taking a look around, making sure we're not missing any areas, make sure we completely treated. And then at the end of the procedure, either a catheter is left in, if it's a particularly large prostate, or people are allowed to choose to try and urinate on their own, if they wish. And we provide them with a backup, which is a catheter that they can put in if there's an emergency, if they feel like they really can't pee at 3 o'clock in the morning. And people have been comfortable with both methods. Once again, this is something that the patient chooses, and it's whatever makes them more comfortable. So after that, they go through a recovery period where a couple of weeks they're irritated, just like they are after any surgery. And then symptoms start to improve after that couple of weeks, and you get a gradual improvement over several months. And that, like I said, it results in about a 50 to 70% reduction in urinary symptoms over that 3-month period. There's now 3-year durability data for it, which shows a retreatment rate of approximately 5% in that 3-year window, which means 19 out of 20 patients in that study were still not requiring treatment for BPH at the 3-year period. So based on that, it provides a couple of benefits. So it's an alternative to meds for people that don't want meds. It can be a primary treatment for people who just don't want to take meds, because I've had probably about 5 to 7 patients who have these symptoms and really hate the idea of taking meds and just would rather not take medicines. And they actually do it without ever trying the meds. Beyond that, 1 or 2 weeks, we give them some samples. They say, I don't like it, I don't want to take meds, let's just do this and be done with it. It provides symptom improvement within 2 to 3 weeks, and then it provides more gradual, complete symptom improvement over the ensuing few months. It's in the office. It's an outpatient therapy, like I said, and most people are doing these under local anesthesia. I have the option of doing either, just for comfort reasons. It doesn't require general anesthesia, but I'll tell you, some people are really happy when they have it. And it preserves urinary function and improves urinary function, more accurately, and it preserves sexual function, as many of the other treatments cause that lack of ejaculation side effect, which people find objectionable. It allows patients to return to regular activities within a few days. What I usually tell people is, if you're going to do the procedure, you may be ship-shape 2 days from now to do whatever you want to. However, I tell people to reserve the freedom to be free of work responsibilities for a week, just in case they want to relax and wait until they're feeling a bit more back to normal. So this is a patient who had Rezūm, is kind of sharing his experience.
You need to know where every bathroom is within a 5-mile radius of wherever you are. I remember there was a time when we were in Spain, and the people we were traveling with were saying, he's always going to find the bathroom, and I always had to. I had pretty well was resigned to the fact that I would have to take medication forever. Well, first of all, it was really expensive. Even though I have Medicare Part D, it still was an expensive thing. Plus, it makes you dizzy, and I'm not so sure I wanted all of that stuff in my body. And so then I made an appointment and said, I've read your brochure and I'd like to consider this. So had a conference with the physician. And, he didn't push me at all. He said, I want you to think about this. And so, you know, I did that, went home. I talked about it with my wife, and I said, I don't see where this is going to lay me up. You know, this should be something that's going to work really pretty well for me. And so I went back to the doctor, made an appointment, and you know, I don't think I was at the clinic for more than an hour. It didn't hurt. It felt weird, but it didn't hurt. I first started feeling relief from the symptoms probably 3 weeks after the surgery, because I had to gradually get off of the Flomax and start taking those pills every other day because you just can't stop with those for 2 weeks. And the Avodart, my urologist said, take it until it's gone. So when it was gone, I was free. Since my Rezūm procedure, I've been able to be free of having to know where the bathroom is right away. I don't have to take pills, and I don't have to pay for them. When I do get up at night, which is about once a night, and I think that's pretty normal, I'm not dizzy. I don't feel like I have to hold on to something. It just kind of really works beautifully. And there have been no side effects. My God, to have the freedom. This is really what has been the end result, is freedom. Freedom is a big thing. I would really say this sets you free. And when you're 75, like I am, that becomes a really important issue. I would say to my friends, and have, about the procedure, it's easy. And if you're thinking about it, do it. It gives you the freedom that you never thought you would have again.
The question you would leave with is Rezūm right for you? And I would expand that to include any procedural therapy. Is that right for you? Rezūm is just the least invasive version of procedural therapy, but do you need to step it up and go beyond medications? And what you would say is, what you would have to ask yourself is, are you tired of the symptoms? If you're not having symptoms, you don't need to do anything about it. If you're having symptoms which bother you, and you're getting bugged by it, it's time to step up therapy. Whatever that is, Rezūm, surgery, whatever works. Is the medication not working for you anymore? That's really a tandem question with the symptoms, right? So if the medication's working, you're not having symptoms, right? You're doing okay. If the medication's not working for you, those symptoms start creeping back up again. You have to think in your back of my mind, am I happier staying the course the way I am, or am I happier making a change? And then, are you dissatisfied with other surgical options? So I've done probably about 130, 135 of these procedures in the past year and a half. And it isn't because I'm no longer doing surgery. I still do surgery on plenty of men who have larger prostates who need surgery. The more formal transurethral resection of the prostate, what people call the rotor-rooter, or the laser enucleation, which I described to you earlier. I still do those, and I probably do just as many as I used to. What the Rezūm has really done is provided an option for men who don't need surgery, who have symptoms that are stronger than the meds, but maybe don't need that laser enucleation or that TURP. So men who are, when it used to be, well, you take the meds till they stop working, then we do the rotor-rooter. It's like, you know, initially you're tickling the BPH with a feather, and then when you go straight to the TURP, you're whacking it with a sledgehammer. There has to be something between those two, and this is kind of, that's in that space where nothing really all that effective was before. And so I've done a lot of these procedures because people saw there was something else out there which resulted in them getting some symptom improvement, but wasn't really that sledgehammer. So with that in mind, if you're interested in talking to me about this or anything, like I said, I do the gambit. This is one of the things that I believe in. But if you're interested in talking to me about this as a first-line therapy or surgery, We're starting medications if you haven't done that, or adjusting medications. I'm here. Just fill out the card. You can go to our website, and that talks about the Rezūm. It also talks about the laser enucleation. It also talks about medication. It just talks about the BPH process in general. And I'm happy to see you whenever you like. And I'm also happy to answer any questions that people might have.